So it's a pleasure to be here, and I would like to thank the organizing committee, especially Francesca and Raphael, to invite me to participate to this very exciting meeting. And it's a shame, but it's my first time in Rome, and it's a pleasure for me. So I would like to provide you some data on our PCDH19 testing in France. And first, I would like to describe our organization, national organization for orphan disease, especially for genetically determined epilepsy. Indeed, we have an association of clinical and biological networks. And you can see in blue the different center of the clinical network on rare epilepsy. And this clinical center is centralized with a unique national reference center for rare epilepsy, which is divided in two entities. The first one at Necker Les Enfants Malades Hospital, which is headed by Olivier Dulac and Rima Nabou, which is devoted to children, and the second entity at La Pitié-Salpêtrière Hospital, which is headed by Professor Michel Bolac and Isabelle Anne, and which is devoted to adults. And there are two national referent laboratories which are associated to this clinical network. The first one in Lyon, in the south of France, which is dedicated to epileptic encephalopathies, early epileptic encephalopathies, and progressive myoclonic epilepsy. And our laboratories in Paris, which is specialized in epileptic encephalopathies associated with febrile seizures and familial form of partial epilepsy. And we initiated the molecular screening, the molecular testing of these epileptic encephalopathies with febrile seizures in 2005. And until now, we collected about 3,300 individuals, including about 2,000 index cases. And I would like to underline that the main indication was Dravet or Dravet-like syndrome, severe forms of these epileptic encephalopathies with febrile seizures. Indeed, 80% of the samples are referred in our laboratory for these two large phenotypical spectrum. In 20%, we have related disease, GEFS syndrome for generalized epilepsy with febrile seizures, of recurrent familial febrile seizures. And I would like also outline that we try to obtain for each samples the clinical data, because it's very important to guide our molecular strategy, but also to interpret the results of our analysis. And we required brief clinical record, or this two-page clinical questionnaire. You have the first page here, and you can have the complete forms in our website. And we don't initiate the molecular analysis without obtaining this clinical data. So, as you know, the first gene that we screened in this phenotypical spectrum is SCN1A, which encodes the alpha-1 subunit of the sodium voltage-gated channel. And you can see that the vast majority of mutations we identified in the Dravet and Dravet-like patients are point mutations in the coding sequence of the genes, including missense mutation, but also nonsense mutation, splice site mutation, small deletion, small duplication, and the vast majority of these mutations led to a loss of function. But in rare patients, we also identified some genomic rearrangements with the deletion or duplication of several exons. This is why for this diagnosis, we performed two techniques: Sanger sequencing to identify the point mutation in the coding sequence, but also MLPA to identify the genomic rearrangement. However, as you can see on this slide, only 70% of patients with a Dravet syndrome had a mutation in the genes. So it remains 30 patients without mutation in the genes. This is why we decided 5 years ago to search for new genes responsible for Dravet or Dravet-like syndrome. And this is why we selected, as you can see, 121 trials with one affected child and her or his two non-affected parents. And we applied the Illumina SNP arrays techniques to detect large genomic rearrangement, to detect copy number variation. And hopefully, as Joseph said this morning, we identified a deletion, only one deletion with this strategy, in a boy. So you can see on this SNP profile of chromosome X that you have here a break. And that break corresponds to the deletion, a deletion on the large arm of chromosome X. And when we focus on these deletions, we identified 4 different genes. And only one of the genes was expressed, since the other genes were pseudogenes. And as you know now, PCDH19 was a very good candidate by function gene. Indeed, these genes was highly expressed in central nervous system, especially during, in Greek too. Yeah. European spirit, okay. So, and this protocadherin belongs to the cadherin superfamily, which comprise different members with a structure containing, containing an extracellular domain which interact with a nomophilic or heterophilic manner with another protocadherin. And for a long time, neuroscientists suspect that this protocadherin can stabilize synapse, as we saw this morning. And this is why we screen this gene in about 73 SN1A negative patients with a Dravet syndrome, and we obtain very, very curious results. Indeed, in our survey, in the vast majority of cases, the different patients were sporadic, and these sporadic cases were due to de novo mutation. However, when you focus on the familial forms, we can describe a very unusual X-linked mode of inheritance. Indeed, the heterozygous females are affected, since the hemizygous males are asymptomatic transmitter. And just when we see these results in our laboratory, we read the famous paper from the Joseph group on protocadherin 19 in familial form associating epilepsy, mental retardation, and febrile seizures. And when you look at the very large pedigrees they describe, you have exactly the same mode of inheritance with heterozygous female affected and asymptomatic transmitted male. So we try to explain this very unusual X-linked mode of inheritance. Indeed, we knew the recessive X-linked mode of inheritance, for example, in dystrophin muscular disease, in which the females are asymptomatic transmitters and boys are affected. In this case, it's the contrary. And for example, in male, you don't have any expression of the protocadein 19, that the vast majority of mutation, we know that, led to a loss of function. In contrast, in females, you have two copies, one copy with the mutation, and we discussed this morning that in females, there are the X inactivation. And the X inactivation corresponds to, in average, in female, 15% of their cells have an active normal X, and in the 50% of cells, this is the abnormal X with the mutation in PCDH19, which is expressed. So all females are functional mosaic. And I would like to underline that the distribution of the inactivation, of the X inactivation, is very different from one female to another, and that the distribution of this X inactivation is very different from one tissue to another in all these females. So there are no correlation between the inactivation in blood sample and in brain, and it's very important to notice that phenomenon. However, we try to explain, as we saw this morning, this very unusual mode of inheritance, and we proposed in our paper reporting the PCDH19 mutation in very severe epileptic encephalopathies, we proposed the theory of the cellular interference. Briefly, I would like to come back to this phenomenon and to this hypothesis, to this theory. In normal individuals, all neurons express the normal protocadein 19. So they form pertinent, accurate neuronal circuits. In mutated males who are hemizygous, they don't express the normal protocadein 19. But we can hypothesize a phenomenon of compensation. So these neurons will express another protocadein, which is functional, and we can assume that they will form correct circuits. So they don't have any clinical sign, neither epilepsy nor mental retardation. However, as I said, mutated heterozygous female are functional mosaic due to the random X inactivation. And in this case, you have two populations of neurons. The neurons expressing the normal protocadein 19, and they will form correct circuits, and the neurons which express the another protocadein. So you have the coexistence in this theory of two circuitries. And this is the coexistence between these two circuitries which led to epilepsy or mental retardations. But we have seen this morning that there are alternative explanation of this phenomenon, of this unusual X mode of inheritance. And I would like to say that these two theories are not exclusive from my point of view. However, Joseph speak about our boy with the deletion. We saw that in blood cell, all cells were deleted for PCDH19. However, we performed a skin biopsy in these boys, and we perform cultures of fibroblasts. And we apply a classical technique of FISH. And you can see that, it's difficult to see that, but you can see that in fibroblasts, you have 50% of cells which are normal, which are not deleted. So in this boy, you have a mosaicism. It's not a functional mosaicism than in females, it's a constitutive mosaicism. And for us, this is why he expressed clinical signs, epilepsy, mental retardation, febrile seizure, and so on. However, I would like to come back to our experience in PCDH19 screening. We initiated this screening in 2009, and until now, we screen about 370 female patients. And we identify a mutation in 66 patients, corresponding to 80% of cases. And we can divide these cohorts in two subgroups. In this first group, we analyze first SCN1A. And in a second step, we screen PCDH19 in SN1A negative patients. And you can see that we identified about 15% of cases with a mutation in PCDH19. In the second subgroup, our clinician colleagues, based on clinical criteria, recommend to us to screen first PCDH19. And you can see that we enrich the cohorts with mutation in PCDH19. And we reach the proportion of 25% in these cohorts. So that we can suspect that from a clinical point of view, we can distinguish between young patients with mutation in SN1A and young female patients with mutation in PCDH19. However, when we screen in a second time SN1A in the negative patients for PCDH19, we did identify mutation in SN1A. That means that there are an overlapping between the two phenotypes. However, I would like to show you the mutational spectrum in PCDH19 in our cohort of patients. The most common mutation are point mutation in the coding sequence of the gene, and you have all the type of mutation we identify in SN1A. This is why we can say that this mutation also led to a loss of function. And we have also rare patients with genomic rearrangement. Large deletion, especially of the first exon of PCDH19, which is the largest exon of the gene, but we have also some duplication. This is why for screening the young females with a suspicion of PCDH19 related phenotype, we have to screen both by Sanger sequencing and also by MLPA to identify genomic rearrangement. So, thanks to this relatively large cohort of 66 patients, we can define the clinical phenotype related to mutation in PCDH19. And here you have the characteristic of our cohort of mutated patients. First, the onset is about 10 months and is older than for SN1A positive patient in blue on this slide, with an average of 6 months. And the first seizure are most commonly generalized or partial. And you can see that absences are very rare as the first seizures. And these first seizures are febrile in the vast majority of cases. And during the evolution, the distribution of the type of seizure can be modified. However, the most common seizures are also generalized or partial. And absences and myoclonic seizures are less frequent compared to patients with SN1A mutation. But as you know, the main characteristic of this seizure is that they occur in clusters in more than 95% of patients with mutation in PCDH19 in our cohort. We have also a high rate of status epilepticus in our cohort. However, I would like to underline, we can discuss, for example, with Carla, that is, in some cases is difficult, for some neuropediatricians, it's difficult to distinguish between some episode of seizures in clusters and status epilepticus. It's my explanation of this very high rate of status epilepticus, okay? And as we discussed this morning, the other characteristic of seizure in patients with PCDH19 mutation is that the frequency of seizures decreases with age. From the neurodevelopmental point of view, I would like to say that in our cohort, 82 patients presented with a developmental delay and a mild developmental delay in 40% of cases. But they have also, after 3 years of age, behavior disturbances, and including autistic features, aggressiveness, hyperactivity, and so on. And after 3 years of age, we have 41 patients with ataxia. The long-term outcome is better for patients with PCDH19 mutations. And I think that we have to perform prospective studies to confirm this opinion, this feeling. And here you have example of young female patients with clinical signs which fits the clinical criteria of Dravet syndrome with an onset before 1 year of age, with seizures which are polymorphic, recurrent, prolonged, pharmacoresistant, and with mental retardation. However, I would like to underline that in our cohort, we have also atypical phenotype. Indeed, we have patients with PCDH19 mutation and with a low sensitivity to fever. You have the example of this young female who had seizures which are not sensible to fever until 3 years of age. And you have also this female with complex partial seizure between 3 months and 5 years of age, which were non-febrile. And it's after 5 years of age that she developed generalized febrile seizures, and in this case, in clusters. So you have a very great heterogeneity in the evolution of the seizures in the patients with PCDH19 mutations. In addition, you have also some very rare patients with PCDH19 mutation and with very rare seizure. It's the case of these young affected females which had only 3 episodes of brief generalized febrile seizures in cluster between the age of 2 and 3. And after 3 years of age, the seizure stopped. However, she developed a moderate intellectual disability. And that proved that there are a discrepancy between the evolution of seizures and the evolution of the cognitive impairment. And I think it's a very important field of research in terms of translational research. However, we have also many cases with seizures, but without intellectual disability, without intellectual cognitive impairment. And I would like to remind you that we screen in our laboratory the most severe form of PCDH19-related epilepsies. Okay? Indeed, in our series, about 20% of patients did not develop cognitive impairment. And it's very close to the publication by Van Artsel and collaborator with a proportion of 22%. And we have very interesting families, like these families. These 3 affected daughters received the mutation from their asymptomatic fathers. They have numerous generalized tonic-clonic seizures in their infancy. However, you can see that the 3 daughters had a very high IQ, above 110. And the 2 oldest daughters are studying in a high-level school of engineering in Paris. So you have also a total discrepancy between the severity of the seizure in infancy and the outcome in terms of cognitive impairment. You have also these very small families in which this young female, 5 years of age, has no mental retardation, but major psychiatric features with social problem, hyperactivity, aggressiveness. So we can see that there is a huge spectrum of phenotype in PCDH19-related disorders, and I think it will be very important to determine the factors, genetic or environmental factors, which can determine these different types of phenotype, because it's very important in terms of prognosis. In addition, you know that the mode of transmission of the mutations are also very different. In our series, the vast majority of cases are sporadic cases. So the vast majority of mutations are de novo. But we have also, in 9 families, the mutation which was transmitted by an asymptomatic father. And in 9 families, these mutations were transmitted by a symptomatic, but also an asymptomatic mother. And I would like to finish by these cases. Indeed, you have these 3 examples which are very interesting, especially these families. This young female with a very severe phenotype received the mutation from both her asymptomatic mother and her asymptomatic grandmother. These 2 females did not develop any seizure nor any intellectual impairment. And in this case, the mutation was transmitted also by an asymptomatic mother, and by molecular biology, we can say that this mutation is de novo. Or maybe this asymptomatic mother is a mosaic, as we saw this morning. And in this first case, we have an intermediate condition. The mutation was transmitted by this mother. This mother never developed seizures, but had major behavior disturbances and a very mild intellectual disability. So, I think that for all the PCDH19 related diseases, we have a very great phenotypical heterogeneity. We have also many modes of transmission of the mutations. So I think that the genetic counseling in these families is very delicate because we have many conditions, many possibilities. The first one is that we have a sporadic female with a de novo mutation. So in this case, you know that the risk of recurrence in this family is very low, corresponding to a risk of a second de novo mutation, 10-6 or 10-5. However, if the mutation is transmitted by a mosaic parent, it's impossible to evaluate the risk of recurrence. The range is between 10-6 to 50% of cases. And the only solution is to quantify the mutation in the sperm if it's the father who is the mosaic. But it's relatively difficult in many cases to do that, okay? However, we have the second great condition. The mutation is familial. There are a segregation of the mutation in the family. And you have two possibilities. The possibility that we have just explored, and the mutation is transmitted by the mother. And in the two cases, the risk depends on the fetus gender. In this first case, all females will have the mutation. So all females will have a risk to develop the phenotype. However, if the mutation is inherited from the mother, we can say that only 15% of females will have the mutation and will have a risk to develop the phenotype. So, in conclusion, I would like to underline that PCDH19 is a very important gene to screen in patients with epileptic encephalopathies associated with febrile seizures, evidently depending on the different clinical criteria. However, we feel that the mutation in PCDH19 are relatively frequent in female patients with epilepsy and febrile seizures with or without mental retardation. And I would like to finish by two fundamental points. The first one is the unusual X-linked inheritance affecting mainly females, and we have many hypotheses that we have to explore to understand this new mode of inheritance. And I would like also to say that understanding the physiopathology of this, of the PCDH19 related disease is very challenging, and we have to join our effort. So I would like to thank you for your participation, for your attention, and I would like also to thank all my colleagues, especially my colleagues in our neurogenetic laboratory at the hospital, at the Pitié-Salpêtrière hospital, but also my research group, the Center for Rare Disease in Paris with Anne Gorfinkel, Rima Nabou, Olivier Dulac, and Michel Bolac, and also all the clinicians of our clinical network devoted to genetically determined epilepsy. Thank you very much.
Thank you. Are there any questions for this presentation of Professor Leguern?
Now, you have said that you have some patients, and of all of your patients, Can you hear me?
Allora, ripeto.
So I'm going to repeat this. You just said that of all of the patients that you have and that you could observe, some 18% of these patients were manifesting some cognitive retardation, mental retardation. And I would like to know, what about the remaining part? And what is the age at which the remaining part of the population was presenting with cognitive and behavioral problems, the ones that you were referring to, such as hyperactivity, relational problems, aggressiveness?
How many of them have behavioral disturbances? Yeah, about 40% of cases in our cohorts. But I would like to underline that in our recruitment corresponds to the more severe form of patients with PCDH19 mutations. And now we would like to enlarge our screening to better determine the limits of the phenotypical spectrum associated with mutation in PCDH19. Since I feel that there are a very large number of patients without mental retardation. However, the clinician colleagues send to us the more severe form because there are a problem of genetic counseling in families. Okay, so you have a bias of recruitment, which is very important. Okay.
La mia domanda è
Now my
anche,
question
volevo capire se
was
avete
also trying to
questo dato,
understand
perlomeno
something
in
else.
termini appunto di media.
I would like to
L'età
know
in
if you
cui,
know at
si
what age, more or less, what is the average age when we do observe mental retardation whenever it's present? What's the average age?
It's very variable, but yeah, very variable. Maybe Carla, you can answer to this question because you're the clinician.
Yeah, I think the majority of patients would probably have a developmental delay probably by the age of 2, 3, maybe 4 at the latest. I don't know if Professor Bernardo della Bernardina wants to say something. I think in our experience that is more or less the age. That doesn't include, although behavioral problems, they can develop probably until later on, some psychiatric symptoms. Then again, I think we should distinguish the acute phase of the psychiatric symptoms when the patients have classes of seizures. Some patients actually might have behavioral problems and acute symptoms, psychiatric symptoms during the cluster of seizures, and then sort of take some time to become normal again and to go into a normal state. And then there are patients with chronic psychiatric problems, and then probably can manifest for the first time even later than the developmental delay. Yeah, I wanted to, maybe Rafael, you can talk about. I just wanted to make like a small comment on the similarities between PCDH19 and Dravet syndrome. I don't know. In our experience, actually, the overlap is not so great. Certainly, there are patients, but I think they're rare, with some seizure onset, especially at the beginning, who might not have a sort of some overlapping clinical features, although the Dravet syndrome usually starts with the hemiclonic seizures. That's really important. Most of the patients with Dravet syndrome would have a hemiclonic prolonged seizure within 1 year of age, and that's really important. And that really doesn't happen so often for the PCDH19 patients. And then if you have the chance of reviewing personally all the clinical data and the EEG, ictal EEG, as we did in this PCDH19 day that we organized in Florence some years ago, and then we published the data, I think most of the seizures are actually focal seizures rather than generalized seizures. And I think that's really important. I mean, not because parents are not accurate enough, it's just that sometimes they miss the onset of seizures. And I think that's really important. Also, that might explain some of the psychiatric symptoms, because often patients with temporal lobe epilepsy, often right temporal lobe seizures would develop psychiatric symptoms independently from the etiology of the temporal lobe epilepsy. So that's that's our experience.
I would like also to discuss with, oh, sorry.
Hi, I was wondering how sure you are that the mutations that you identify are actually causative, right? So because of the way you're doing the experiment, right? You're essentially sequencing just that one gene, and then you're including in as sort of your hits missense mutations and things like that that may in fact not be causative in those cases.
Yes. When we found a variant in a gene which fulfilled the list of criteria corresponding to a mutation, we stop the analysis. So our criteria are very classical. This is the absence of the variant in the data bank of human polymorphism. It's amino acid residue which is mutated, which is well conserved among species. It's also the use of predictive software on the deleterious characteristic of the variant. However, it's not a proof. Okay, I agree with you. However, now we will have new technology permitting to screen all the different genes incriminated in the PCDH19 related phenotype in one shot. And I'm sure that you said that we will find different variants in different genes. And I think it will be very difficult to interpret this genomic data. And this is why we need the clinical reports to distinguish between the different variants we will find by these new technologies, and to test the other members of the families, to study the segregation of the variant in the affected members of the families. It will be a very huge amount of work to decide which is the causative variant.
Francesca, in my experience, mental retardation and psychiatric autistic feature are present after 2 years of life, and in some cases also before. This is for you. I'm not sure that I not agree the overlapping between Dravet syndrome and PCDH19 patients. We have the Italian experience, as said Dr. Marini, with the electroclinical features that will show by Dr. Trevisano in the after session. In 4 or 5 our patients, the genetic diagnosis was done after the first cluster of seizure. Okay.
So
maybe
you follow the evolution.
Absolutely.
Oh, okay.
And after I will show you a little neuropsychological and cognitive outcome in a little group of PCDH19 patients. And the aim is to study a large cohort, Italian or in the world. It's better to follow the neuropsychological and cognitive at the onset characteristic in these patients with 2 aims. The first is for the girl. The second is for us, for scientific people, And the third, most important, is for the family,
In terms
for
of prognosis,
rehabilitation and therapy.
How many patients do you follow
In,
with this protocol?
in Italian, 40, 47, 50. Nico.
50? Oh, it's a very large cohort. So
Yes.
Okay. And you will finish this protocol in 2 years, 3 years?
1 year.
1 year. Okay. Splendid.
Let me get to that part.
Sorry, I have last just a little question, apparently. In your opinion, there is an overlap between PCDH and Dravet syndrome. I know very well the position of Olivier, Rima, and the interest from the therapeutic point of view of this position. The history is perfect. You find the PCDH deletion in a population having apparently, in my opinion, the phenotype, the electroclinical phenotype of Dravet syndrome. But now, do you think that the only modality for the early diagnosis is to go to the genetic test? If yes, we must separate the scientific reason for this genetic test and the clinical reason, because looking at all the atypical cases that you show, we must go to do the genetic test following the criterion if male SCN1A, also in all children having the first febrile convulsion in the first years of life, because you can't know at this moment if it's Dravet syndrome, PCDH, or simple febrile convulsion. If you take only few months of follow-up, I think is in the majority of the cases distinguish, like stressed by Carla, if it's probably PCDH or probably Dravet syndrome. What is your opinion?
Yes, I have the same conclusion. It's probably SN1A, SN1A positive patient, or probably a PCDH19 related disease. However, I think that by genetic testing, we can give a quasi-certitude. Okay, so I think that we have a pressure from clinicians to very quickly confirm the diagnosis by molecular biology. It's not our opinion to screen all patients with 2 or 3 febrile seizures, but I can say to you that the clinicians, after 2 or 3 febrile seizures, relatively prolonged, they send to us the blood samples. And we have we had the discussion with Olivier. Olivier said also we can well define Dravet syndrome and so on. However, many colleagues, clinician colleagues, send to us the DNA in order to screen the different genes. And with the new technologies, yes, I think that this way of thinking will be reinforced.
Yes, but you have reason, because the example that you done, the difficulty from some clinician to distinguish between seizures in cluster and epileptic status is coming from the fact that you have epileptic status corresponding to a long-lasting seizures. You have you can have seizures in cluster, but you also can have status epileptic of seizures recurring in cluster very frequently. I see anyway a risk from the clinic's point of view. You surely know the Japanese work looking at how the clinician aptitude and diagnosis has been modified by the genetic test.
Sure.
So you know the problem with SCN1A, the problem that a lot of people have a diagnosis of Dravet syndrome with poor prognosis. In fact, they have no Dravet syndrome,
yeah, sure.
but febrile seizures plus or something like this. Okay, thank you.
I would like to take a comment. You have also in our large clinical network, you have some neurological department which are specialized in epileptic encephalopathies, especially with febrile seizures, and other departments which are not specialized. And you have different expertise, okay? And I think that the importance of the genetics testing depends also on the expertise of the different center. I'm convinced of that.